Hi guys, today's our topic is physiology of pain. So we'll talk about what is pain, how it is transmitted to the cortex, and what is pain analgesia system. And also we'll talk about the referred pain. So what is pain? It is the unpleasant sensory and emotional experience which is associated with actual or potential tissue damage. So any tissue damage or any injury which is nearer to the tissue damage will cause an unpleasant sensation. We call that as pain. And pain when compared to the other senses is different because it is associated with an affective component like fear, anxiety. So an affective component is there and is also associated with a reflex. Let us think that you stepped on a thorn. You immediately withdraw your limb over that. So that is called as a flexor response or withdrawal reflex, and is also associated with autonomic symptoms like rise in heart rate, BP, respiratory rate, and sweating. So increased sympathetic activity. So pain is different from other senses with one affective component and one with withdrawal reflex as well as autonomic responses. And coming to the different types of pain, we can say that there is fast pain versus slow pain. So any pain immediately after the injury is fast and is sharp and localized. After few minutes, it becomes diffuse and dull and is not such a localized thing. So sharp localized pain which is immediately after the injury is called as fast pain, and diffuse dull pain is called as slow pain. And A delta will be carrying the fast pain and type C will be carrying the slow pain. So A delta is a myelinated fiber and can carry the pain sense fast, whereas type C fiber is unmyelinated and carries a bit slower. Superficial pain versus deep pain. Simple. Skin and subcutaneous pains are called superficial. Muscle and bone pains are called as deep. And the deep usually is carried by type C. Acute versus chronic, depending upon the duration. If the pain is of sudden onset, we call that as acute. And if the pain is for a longer duration, we call that as chronic. And somatic versus visceral. Somatic is the sense we can say that it is from the skin, muscle and other. Visceral is from the smooth muscles or the intestines or the organs. We call that as visceral pain. And coming to the pain pathway. So we are having the pain pathway which is lateral spinothalamic tract which is carrying the pain and temperature. Our concern is pain. So I will again brush up what is lateral spinothalamic pathway. If we take this as the spinal cord and this is the dorsal root. So there is a dorsal root ganglion which is the first order neuron, and from there the second order neuron starts and crosses to the opposite side, goes to the thalamus, and from there to the sensory cortex. So first order neuron, second order neuron and third order neuron. Finally it goes to the sensory cortex. Third order comes from thalamus. So this is the lateral spinothalamic tract. In that we have two kinds of lateral spinothalamic tract. One is paleospinothalamic pathway and the other is neospinothalamic pathway. So phylogenetically, paleo means older version. Paleo is evolved late. Okay, neo, most evolved pain pathway is neo. So it is called newer version. So neospinothalamic pathway. So only prime difference between paleo and neo is usually paleo will be carrying the slow component of pain, we can say that, or with visceral pain, and neo is concerned with the fast pain. So the same story, the first order is common, second order is common, third order is common. Only that in paleospinothalamic pathway, the second order neurons will also give collaterals to some other structures. But in neo, it directly goes to the thalamus. And also in paleo, it is non-specific nuclei in thalamus, whereas in neo, it is specific nuclei in thalamus. So we'll talk about all those things in the next slide. So paleo means phylogenetically it is older pain system and it carries slow pain. And first order neuron is dorsal root ganglion. We already mentioned the slow pain is carried by type C fibers and the neurotransmitter released is substance P. And so the first order neuron will end in type 2 lamina of dorsal greyhound. So type 2 laminae, and from there the second order starts, which crosses to the opposite side and forms contralateral spinothalamic pathway. And as we said, the paleo will give collaterals to other structures like reticular formation in medulla, periaqueductal gray matter in midbrain, and also hypothalamus. So this is the diagrammatic representation. You can see here this is the lateral spinothalamic tract, and if we take about paleo spinothalamic pathway, it is giving collaterals in the reticular formation as well as periaqueductal gray matter as well as in hypothalamus. And the third order neurons will start from intralaminar nuclei of thalamus, which are non-specific. So slow pain is non-specific. If you see the fast pain fibers without giving any collaterals are going to the ventrobasal complex. We call that as ventroposterolateral nucleus of thalamus, which is a specific, and it goes to the somatosensory areas. And the third order neurons, as we said, starts from the medial nuclear group of thalamus, which are non-specific, and they terminate in the sensory cortex. And coming to the special features, as it is non-specific, poorly localized, so we can't pinpointly show the slow pain. We will show the slow pain like this. We can't point it. So it is poorly localized. And as it is giving collaterals to the reticular formation, the person with slow pain can't sleep. So he remains awake. And the periaqueductal gray matter, which is a component of limbic system, will cause the emotional aspect, either fear or anxiety. And hypothalamus will cause the sympathetic activity by increasing heart rate, BP, respiratory rate. Coming to the neospinal thalamic pathway, newer one, and it carries the fast component of pain. So the fiber here is the A delta. So first order neuron is dorsal root ganglion of A delta fibers, and they go and terminate in lamina 1 and 5 of spinal cord. And the neurotransmitter here is the glutamate and substance P, and from there the second order neuron starts, which crosses to the opposite side, ascends up and gives synapse to the thalamus ventroposterolateral nucleus, which is specific nuclei, from there to sensory cortex. And topographic representation, let us think that this is the cervical segment and this is the thoracic segment and this is the lumbar segment. So let us think that this is the lateral spinothalamic tract of lumbar segment, which crosses to the opposite side and goes laterally, and the thoracic ascends medial to that, and cervical ascends still more medial. That's why cervical is kept in the medial part and sacral is present in the lateral part. This is the topographic representation of neospinothalamic pathway. And as we mentioned, ventroposterolateral nucleus, which is specific, and third order to the cortex with the similar topographic representation. The special feature is localization. We can pinpointly localize the fast pain component. And intensity discrimination, there will be intensity of pain varies. So we can know severe pain with mild pain. So intensity discrimination is possible. Coming to the deep pain, which is arising from the muscles, tendons and bones, is poorly localized because of number of receptors are less, and is associated with autonomic symptoms, and is also associated with the contraction of the muscle, which causes ischemia, constriction of the blood vessels in between these muscles, and that causes ischemia. That still aggravates the pain. So it's like a positive feedback. Coming to the visceral pain, which is the pain that is coming from the visceral. So it can be like a aching pain, or ulcer pain appears like a burning, or anginal, which is seen in myocardial infarction, and is poorly localized because of less number of receptors. Even this pain also we can't pinpointly show, we'll show with a broader area. And stretch or distension of viscera, obstruction of the intestine, or overinflation of the intestines, they cause stretch and distension of viscera, which causes the pain. And it is also associated with the affective component, vomiting sensation, vomiting association, and autonomic symptoms like sweating and tachycardia. And if the abdominal viscera they are injured and there is peritonitis, there occurs guarding of the muscles above that. The muscle guarding is also present with visceral pain. And visceral pain, it presents as a referred pain. So what is this referred pain? We'll see. So referred pain is the pain in the somatic sensation, somatic structure, due to the injury of viscera or irritation of the viscera. So in the somatic structure due to visceral irritation or injury. So let us think that if this is the heart region, which the pain is felt along the ulnar border of the heart. So pain is ulnar border of the arm. So heart is here, but the pain will be perceived here. So it is the pain perceived in the somatic structure due to the irritation of nerve injury, due to the irritation of the viscera or injury to the viscera. And why so? Why the pain is not presented deeply? Why it is presented to a somatic structure? There are some theories which explain this. One is dermatomal theory, 2 convergence theory, 3 facilitation theory, 4 experience theory. So what is this dermatomal theory is? It says that from embryo, both the structures are derived from the same dermatome. So like heart and inner aspect of the left hand. That's why pain is felt over the ulnar border. So they are from the same dermatome. That is one theory. Convergence theory. What this mentions is, if you see here, this is the somatic structure and this is the viscera. Heart is there. Now the afferent from this heart is going and synapsing with a neuron. Similarly, the afferent from the skin is going and synapsing with the same neuron. So they are converging on the same second order neuron. So the pain from here is perceived like pain coming from here because they are converging on the same second order neuron. Coming to the facilitation theory. What is this facilitation theory is, if you see here in the diagram. So this is from visceral afferent. So this visceral afferent is giving a collateral to the somatic afferent. Now what happens? Let us think that this somatic, which is to the skin, is stimulated slightly. So slight stimulus may cause pain in the somatic sensation because the viscera is already injured and it is giving its collaterals to the somatic afferent, and this is facilitating the transmission in the somatic afferent. So that causes the facilitation theory, referred pain. And experience theory. Usually a person's inflammation of abdominal viscera is referred to a midline. But in persons with previous experience of pain, the pain is referred to the site. Let's think that the person is having a surgery scar. Let us think that he is having an appendicitis scar. Now the pain in the abdominal viscera will be transmitted to this appendicitis scar. So that is called as experience theory. So these are the theories of referred pain: dermatomal, convergence, facilitation, and experience theory. And coming to the recognition of pain, how pain is felt. One, any tissue injury that causes release of proteolytic enzymes. One, or the local hormones like histamine, bradykinin, potassium and serotonin. All these can stimulate the free nerve endings, and these free nerve endings, which may be A delta or type C, will release a neurotransmitter which is substance P. So the neurotransmitter that is released at the spinal cord level is substance P. This will be stimulating the second order neuron. So modulation of pain perception. Let us think that if I touch a normal intact skin, I may not feel the pain. But if there was an injury, a small touch can cause the pain. So threshold of pain is lowered there in inflammation. And also if you see, if anesthetic is given, local anesthetic, we don't feel the pain because there rises the pain threshold. And distraction and strong emotions will reduce the pain. Usually in war field, even though they have an injury, they will end the war and they'll come out because there's strong emotion, they don't feel that pain. So distraction and strong emotion reduces the pain. Coming to the pain control mechanisms. So even though there was an injury, the pain is perceived. So the pain is like a warning sign that you had an injury, be cautious. Once it is perceived, our body tries to reduce the pain. How it is done? So the pain control mechanism, we have one is descending pain modulating system, or we call that as descending pain analgesia system, and endogenous opioid system, and there is one at the spinal cord level, that is gate control theory, and another one is stress induced analgesia. So these are like central levels, this is like a spinal level, and this acts both. Now we'll see descending pain analgesia system. Now the pain is perceived. Now the frontal cortex and hypothalamus are activated. They will activate periaqueductal gray matter in the medulla, which in turn activates nucleus raphe magnus. This nucleus raphe magnus will release serotonin. So the serotonin will act over 1, 2 and 5 lamina, which are nothing but the second order neurons origins. So they will release serotonin. So serotonergic pathway. Now in this spinal lamina, there is a presynaptic neuron, which is an inhibitory neuron, which releases enkephalin. This enkephalin will cause presynaptic inhibition, or so presynaptic inhibition is done. So less substance P is released. So less substance P means pain is less perceived. So that's how pain is reduced. So frontal cortex or hypothalamus is sending the information to periaqueductal gray matter. Now the periaqueductal gray matter is activating nucleus raphe magnus, which is releasing serotonin, which is acting over the interneuron in 1, 2, 3 lamina, 1 to 5 lamina. This inhibitory interneuron will release enkephalin that causes presynaptic inhibition and less release of substance P. So the same, now the frontal cortex and hypothalamus are acting over the periaqueductal gray matter, which releases enkephalin and activates nucleus raphe magnus. This nucleus raphe magnus is releasing serotonin, which is acting over an inhibitory interneuron which releases enkephalin. That causes presynaptic inhibition which causes decreased release of substance P. So pain is not transmitted much. Another one is there which is called as cerebrospinal noradrenergic pathway. So similar to the raphe magnus, locus coeruleus of Pons is directly stimulated, no inputs from periaqueductal gray matter. It comes to the spinal cord dorsal root and it inhibits the transmission from primary efferents. Similar presynaptic inhibition. Now endogenous opioid systems. We know that there is one potent analgesic, that is morphine, which is produced endogenously. So endogenous analgesic, morphine is the potent one. How it acts? Usually they bind to opiate receptors which act through G protein coupled receptor, which activates GQ subunit. that inhibits the adenyl cyclase. Adenyl cyclase is inhibited, and this can cause both pre and post synaptic inhibition. So pre synaptic inhibition is by decreasing substance B, and post synaptic by increasing K plus conductance. So K plus conductance causes hyperpolarization, no transmission. And not only morphine, we have some substances like endogenous morphine-like substances, we call them as endorphins, and anacephalins, beta endorphins, gamma endorphins, and dynorphins. These are all endogenous opioid-like substances. These act both pre and post synaptic. Pre by releasing less substance B, post by increasing K plus conductance. And gate control theory. What is this gate control theory is? If we see here, these are the A beta fibers and these are the type C fibers. Let us think that. And these are carrying the somatic sensation, and if you see, they are stimulating an inhibitory neuron as well as they are stimulating the projection neuron which goes to the thalamus. Now the small fibers which are carrying the pain are inhibiting the interneuron and stimulating the projector neuron. And if this inhibitor neuron is activated, that will inhibit the projector neuron. Okay, simple. So now let us think that only type C or the small fibers are activated. They will inhibit the inhibitory neuron. They will stimulate the projection. That means pain is transmitted. Okay, now simultaneously I am stimulating the somatic neuron. Now what this somatic neuron is doing? It is stimulating the inhibitory neuron. If it is stimulating the inhibitory neuron means the projection neuron is inhibited. So pain is not transmitted. So stimulation of large fibers closes the gate that reduces the transmission. So this is gate control theory, and we routinely use this application. Acupuncture works on gate control theory. Counter irritants, whenever we got a body pain or headache, we'll just apply some counter irritant like Gendubomb. What that will do is, it will stimulate the large myelinated fibers which will suppress which will close the gate, so no transmission. And even TENS, which is used as a treatment for the nerve injuries, transcutaneous electrical nerve stimulus, that is TENS. Stress induced analgesia. So as we mentioned, when a person is working in a war field, even he got a grievous injury, he will fight. So it acts through both opioid and non-opioid mechanisms as well as descending analgesia system. So it acts through all the ways. So this is how the pain is inhibited or pain is less transmitted. Thank you for your patient listening. Bye.